Makes sense, right? So the drugs that, if it's just in this bucket, we can get to it. If it's in the cells, we put those back, and if it's distributed between both compartments, we can get to this, but we can't get to that, okay? Okay, so let's talk about some drugs, for example. Drugs that are limited to the intravascular space, so they're only in this bucket. Our apheresis device is going to draw that out. It's going to put stuff in the waste bag and it's going to replace it. So that's my lovely apheresis device here, right? So this is where the replacement's coming back into my bucket, right? It is going to, if it's limited to the intravascular space, it's going to be effectively removed. So what are some examples? Well, things like rituximab, things like IVIG, so any of the MABs, any of the monoclonal antibodies. Why? They're big molecules, they're immunoglobulins. You know, we treat a lot of diseases that are caused by autoantibodies, right? With plasma exchange. So it makes sense that these things, which are big, are limited to the intravascular space. We're going to remove them. Similarly with IVIG, okay? This one, Digibind. Digibind is a piece of an antibody that recognizes the digoxin or digitoxin, okay? So if somebody overdoses on their digoxin, you can give them Digibind. And what Digibind does is it binds to the digoxin, making it unavailable, so it's not affecting their heart. They're not having arrhythmias and dying from their digoxin overdose, okay? So the digoxin is not removed, but the combination of the Digibind to the digoxin would be removed, okay? So these complexes are removed. And this actually can be useful. The digoxin Digibind complex is predominantly excreted in the urine, so you pee it out. So if you have somebody that has renal failure, okay, they're not peeing, and they took a whole bunch of digoxin, and you give them Digibind, suddenly they're feeling better, right? Because it's all, the digoxin's all bound up. And they start feeling bad again because the Digibind and the digoxin start breaking down, and all of a sudden the digoxin's available to affect their heart again. And they can't excrete it because they're not making urine. You can go ahead and do a plasma exchange. You do plasma exchange, you're going to remove that complex. And so there are people that have reported the use of plasma exchange in digoxin poisoning, but only when they've given Digibind and it's somebody who has renal failure and can't excrete the digoxin Digibind. Okay? Does that make sense? And this is, again, one of those reasons why when we have patients come and they just gave the IVIG, or they just gave the rituximab, and we're going to do the plasma exchange, that's sort of a waste of a whole boatload of money, because we're going to remove all this stuff. Okay? So that's why if somebody is getting IVIG or rituximab, plasma exchange first, administer those medications after. And that's why for the nurses in the room, sometimes we say, you know, Mr. Smith has to be at 1:30 or Mr. Smith has to be at 8 o'clock. Why? Because we have an infusion of IVIG or rituximab scheduled for whatever time, and we need to make sure that that infusion occurs after the plasma exchange. So we can't adjust the schedule to move the patient later in the day, because then what will happen is we'll remove the drug. Okay? Okay, drugs that are sequestered within cells. We already mentioned this, like cyclosporin and tacrolimus. Because we don't actually remove the cells, we don't actually remove the drug. And so it's protected, and we're not going to remove it. So again, I had mentioned cyclosporin. People have attempted to do cyclosporin overdose with plasma exchange. It doesn't work. This is in the red cells. So you remove an insignificant percentage of the dose, 1%. The same would be true of tacrolimus and sirolimus and some of these other medications. Okay? Any questions about that? Okay, drugs distributed between both the intra and the extravascular space. So these are the drugs where we can measure it in the plasma, but it's also out in the tissues. It's out in the body water. And in prednisone, that's something a lot of our patients are on steroids, right? We remove an insignificant amount, only 1%. Cyclophosphamide, a chemotherapeutic immunosuppressive agent, has very low protein binding. Because it has such low protein binding, it is not effectively removed, even though it is circulating in this intravascular space. Azathioprine, okay, another immunosuppressive agent. It also has low protein binding, so it's not effectively removed. The ones with the red check marks, those are the ones where there are issues. So for cisplatin, it has very high protein binding. So even though it's in both compartments, we can remove at least what's circulating here because it's bound to the proteins. Same is true for vincristine. We talked about digoxin, so we'll need to talk about that further. Again, propranolol, verapamil, diltiazem, so these cardiac meds, okay? Again, high protein binding. Quinine, while there is some quinine in the intravascular space, most of it is extravascular, so again, we can't get to it. And propoxyphene, again, it has low protein binding and predominantly extravascular, but there are reports that it is effectively removed. I don't have an explanation as to why. And those with the little crosses next to them, those are the ones in the literature where people have reported treating overdoses with plasma exchange in those settings. Okay? I think there was one time we were asked to do cisplatin in a cisplatin patient.
And we did the quinine too.
Yeah. Well, we've done quinine for, I think, the quinine-induced TTP,
Yeah.
not necessarily the overdose. Okay? Does that make sense? So the key characteristic is if it's in both places, it's got high protein binding, we may remove it. Okay?
So if patient is on, for example, vincristine, so do we need to warn or?
We should. We'll get to the last few slides at the end. They'll give you some guidelines on what you should say. Okay. Again, more drugs. Acyclovir. A lot of our patients are on acyclovir. Low protein binding, so don't care. Okay. Ceftriaxone. So they're on antibiotics. Okay. So high protein binding, and the volume of distribution is dose dependent. So if it's a really big dose, it's going to be distributed, the volume of distribution is going to be pretty large. If it's a small dose, it's going to be a small volume of distribution. Most of it's going to be in the bloodstream and will be removed. Ceftazidime, chloramphenicol, again, 2 antibiotics, removed. So you would have to adjust the dosing. Vancomycin, predominantly outside the bloodstream. Tobramycin, predominantly in the bloodstream. So again, it's going to be removed. Some of these lovely agents that are used to treat seizures, thankfully, most of these are extravascular. And they're mostly in the CNS affecting the seizures. So we don't see, thankfully, people breaking through and having seizures when we're doing plasma exchanges for intractable seizures or somebody with some sort of autoimmune brain disease that's causing seizures. There are some reports in the literature that phenytoin, that you can remove a significant amount of the total body stores, but the free fraction, that's the part that's active, the part that's not bound to proteins, remains unchanged. So once again, you usually do not have to adjust dosing, you don't have to do much to these, okay? Which is actually, I think, a good thing. But for these antibiotics, you might need to adjust the dose, okay? You might need to give more, because we're going to remove some.